Good afternoon, Dr. Hickman. Many years ago, you refused my repeat prescription request for my asthma inhalers. Oh, great. Here we go. Another complaint. You told me to make an appointment to see you. I wasn't very happy. I was a fit chap, trained every day, and couldn't see the point. I explained that I'd take one puff of my blue inhaler before training, can train to the extreme, and I had everything under control. You explained that I wasn't in control and explained why. Since that first chat, I can't remember the last time I used my blue inhaler. I thought I was doing ACE. You challenged that, and I'm better now than I was at 20 years of age, and I'm now 53. In short, you changed my life. Boom! You taught me to better manage my asthma. You're an amazing doctor. Thank you so much. Wow! Who would have thought it? I am an amazing doctor. It's not every day you get called an amazing doctor when you work in the NHS. Quite frankly, mwah, my job is done here and there's nothing else to say. Thank you. Goodbye. An amazing doctor. What does that even mean? Definition of amazing. Causing great surprise or wonder. Astonishing. I bet plenty of Harold Shipman's patients described him as an amazing doctor, and that didn't exactly end well, did it? I'm not an amazing doctor. I didn't do anything amazing for that patient. What I did do, though, was provide him with basic, good asthma care. Not rocket science, nothing groundbreaking, nothing amazing, just the absolute basics. I provided him with the knowledge so that when he walked out my door, he knew what to do with his asthma for the 364 days of the year when he wasn't at the GP surgery. Now imagine for a second that I hadn't had that 3-minute conversation with my patient. 3 people die of asthma every single day in the UK, and many, many more have life-threatening asthma attacks. Not all asthma deaths are preventable, but it's widely accepted that there are preventable factors in 90% of asthma deaths. If I'd not had that 3-minute conversation with my patient, he could easily have been yet another statistic. Patients with asthma should be prescribed 2 inhalers. One is their prevention inhaler that they are supposed to take regularly every day. This dampens down the inflammation in the airways, keep their airways open, essentially keeps them alive and stops them having to rely on their blue reliever inhaler. Blue inhaler or rescue inhaler gives them instant relief when they're breathless by relaxing the muscles around their airways, but does nothing to treat the underlying inflammation. The inflammation that builds up and builds up and builds up, and if not treated, eventually leads to an asthma attack or, worst case scenario, death. A patient with asthma should get 1 preventer inhaler a month and 1 blue reliever inhaler a year. Well-controlled asthma is defined as not having any symptoms of asthma. So where is it all going wrong? According to Asthma UK, 3.24 million people in the UK are still not receiving the most basic level of asthma care, and patients are not being given the right message. The message that if they take their steroid inhaler morning and night, and in some cases just once a day, they dramatically increase their chances of a life with no daily symptoms of asthma. A life where they don't run the risk of a life-threatening asthma attack and reduce their chances dramatically of dying from asthma. Patients, because they're a human and just like you and I, let's face it, forget to take their preventer inhaler. Not only am I a GP, but I also teach behaviour change to help people make habits stick. Can I remember to take a 3-day course of antibiotics? Can I hell? But is it that they simply forget to take their inhalers? Or is it that the message hasn't been given, or if it has, hasn't sunk in? 12 years ago, I was a GP with little interest in asthma. I would think nothing when prescribing a steroid inhaler to also prescribe a reliever inhaler every month. It never occurred to me that this might be a sign that the patient's asthma might be poorly controlled, that they weren't taking a prevention inhaler either at all or properly, and they were symptomatic on a daily basis, relying on their blue inhaler for relief. In 2009, at my first meeting as a GP partner, we divvied up our clinical roles. I said categorically that I would do anything apart from respiratory, as I really didn't understand it, and in fact, actually failed respiratory physiology at university. Despite my protestations, I was given the role of respiratory lead, and I embraced it, the opportunity, knowing full well nobody else was going to take it on. And my passion and love for the subject started there. Fast forward to 2012, and I found myself at the training day to be part of the first ever national review into asthma deaths, or NRAD. This was to be my light bulb moment, my epiphany. I watched the lead of the audit, Dr. Mark Levy, talk with such passion about why something had to change. Patients were continuing to die of asthma every day in the UK, and many more were having life-threatening asthma attacks. His drive and energy was infectious. Being part of NRAD, though, was a bit like watching the Titanic for the fourth or fifth time. You know what's going to happen, but there's part of you that wishes that the Titanic does not hit the iceberg or the patient does not die. The clue is in the title. The patient who had been prescribed blue inhaler after blue inhaler without anybody checking whether or not she was taking a preventive steroid inhaler. The patient who, after her last trip to the asthma nurse, was found dead with a blue inhaler gripped in her hand, her inflamed airways closed shut. She was the same age as me. It still makes me feel sick when I think of the terror she must have experienced as her airways closed shut for good in the last minutes of her life. She was let down at every stage of her care, let down by amazing GPs and nurses who I know did not set out to cause harm, but ultimately did not identify what she needed in her appointments and did not provide the most basic level of asthma care. Most GPs will get allocated 10 minutes appointments to see their patients. Asthma may be only one part of that 10 minutes. Once the patient has walked down the corridor, taken off their coat, settled themselves down, talked about the weather and their poorly dog, there is often considerably less time than 10 minutes. A few GPs will get a bit more, maybe 15 minutes, and a handful will get less. But imagine if we ran our surgeries like teachers ran their lockdown parents' evenings. Hands up anybody who had a lockdown parents' evening. They were great, weren't they? Whoever designed that platform was a genius. They recognised a few things. Teachers are busy. They have a stressful job looking after our kids. There is nothing that a parent wants to do more than talk about their little darlings for hours on end to their teacher. But what happens if this is allowed to happen? The teacher runs later and later and later. Other parents get angry, the teachers get angry, and the next day they are exhausted and struggle to cope with the demands of a full classroom of our kids. So what happens after 6, 8, 10 minutes, or whatever allocated time has passed with the teacher? 5, 4, 3, 2, 1. Blank screen. Time's up. Genius. At the end of the 6 minutes, my husband and I weren't looking at each other with shocked incredulity because we knew exactly what was going to happen. I, had read the instructions beforehand. We were warned. We knew the teacher had other parents to see, other conversations to be had, and if we couldn't cover anything in a 6 minute slot, we can book a longer appointment. The school had contracted with us, and it worked. So, how many of your GPs have contracted with you? I suspect, unless you are a drug addict, none. How many have been explained beforehand that your appointment is only 10 minutes long and you'll be given a 1 minute countdown and the appointment will end? I hazard a guess that the closest any of you have got to a contract is a notice in the waiting room saying something along the lines of one patient, one problem, one appointment. Because more often than not, when you go to your GP, you can go on for as long as you like, because just as we love to talk about our kids, we love to talk about ourselves even more. And because there is never a contract in place, none or very, very few GPs are going to stop you. GPs constantly moan about not having enough time with their patients. Patients constantly moan that they want more time with their GP. We all want more time. In fact, the Royal College of GPs' core vision for the future of general practice is to put an end to the standard 10-minute GP consultation, to allow GPs to spend more time with patients with complex needs and provide a more holistic approach to patient care. Are longer appointments really the solution? And if implemented, could this put even more strain on a system that is already collapsing under the strain of sicker patients needing and wanting appointments? What if we could accept the 10 minutes that we're given to see our patients and focus more on what we do with that time? Recognise that, yes, some patients will need considerably more time than 10 minutes. The patient who is having an asthma attack needs a nebulizer and an ambulance calling. The patient that needs to have an end-of-life discussion with their GP, or a patient that's having bad news broken to them about a new cancer diagnosis. Yes, they will need longer, but many won't. What if GPs didn't need more time, but were able to establish the one thing in that 10 minutes that their patient needed and provide them with basic care? Identify the one thing that may end up saving their life. What if a contract had been agreed beforehand that after the 10 minutes was up, this would signify the end, and assuming they didn't need urgent attention, they could book a follow-up appointment at their convenience, whether that be face-to-face, via a text message, a phone call, or a video link. We can get so engrossed in ticking boxes and earning income points that we can sometimes forget the patient sat in front of us, what they truly need, and what basic good care looks like for them. Take asthma, for example. What if a GP could identify the one thing that ensures their patient knows why they are taking inhalers daily? Identify the one thing that could do for their patient during the consultation that ensures they know what to do in an asthma emergency. And identify the one thing that ensures their patient knows how to take their inhaler correctly. What if the patients, the statistics who made up the cohort of the National Review into Asthma Deaths had known how to take their inhalers, had known why they were having to take a Preventer inhaler daily, and had known what to do in an emergency? Could there have been some very different outcomes? In the next 3 minutes, I'm going to demonstrate 3 things that, if covered in every patient's appointment who has asthma, I believe could lead to significant improvement of asthma care in the UK. As you can see, this is a wide open airway and air is able to flow easily through it. The surrounding muscles are nice and relaxed. These are airways of somebody with asthma. The muscle bands are tightening around the airways. Your rescue inhaler, which tends to be blue, relaxes these muscles on the outside of the airways. It is a quick reliever, makes you feel better, but the relief is temporary and only lasts a few hours. The muscles are relaxed by the rescue inhaler, but you can see from this model that there is a lot of inflammation on the inside of the airway, how narrow the opening has become. And this is because your blue inhaler only works on the muscles on the outside of your airway and does nothing for the inflammation on the inside. If left untreated over time, the inflammation gets worse. And you can see from this model there is now also mucus plugging up the airway. When the airways are narrow like this, it can be difficult to breathe and you may cough or wheeze. If left untreated over time, the inflammation gets worse. And you see from this model, this is why you need a Preventer inhaler that you take regularly every day. They work slowly over time, are long-lasting and reduce the inflammation while opening up the airways. If taken properly, airways can look like these. If your asthma is well controlled, you shouldn't have to use your blue inhaler at all. How about you start to think that your blue inhaler is like a blue light on an ambulance, a warning sign, i.e. if you're using your blue inhaler on a regular basis, you're more likely to end up needing an ambulance because your asthma is not well controlled and inflammation is building up. Equally, remember it's important to always carry your blue inhaler around with you everywhere, as it will help you in emergency while you wait to see your GP or for an ambulance to arrive. In an emergency, you can use your inhaler with a spacer up to 10 puffs every 30 seconds. Imagine a world where patients with asthma left their doctor's surgery not grateful that they'd spent an extra 5 minutes with their GP, but grateful that they knew how to take their inhalers, why they were taking them, and what they needed to do in case of emergency. Grateful because the GP had identified the most important aspect of their care in that 10 minutes, the one thing that was going to have the biggest impact on their asthma care, and the one thing that might even prevent them from dying or having a life-threatening asthma attack. A world where preventable asthma deaths became a thing of the past, a never event. They didn't feel fobbed off because they knew beforehand what was coming. They had contracted with their GP. They had been allocated a 10-minute appointment, and when time was up until the next appointment. This doesn't, though, of course, just have to be about asthma. Think of the possibilities for all manner of ailments if we just stop focusing on the quantity of time with our GPs, but focus on the quality and the one thing that was going to have the biggest impact on their lives as they walk out of our door. Thank you.